This is Ian Bodford.
And Wang Liu.
And welcome back to the Clinical Correlation.
Today we present
And that's all, folks.
Part 1.
We started the year with a case of a 65-year-old male with chest pain who is now chest pain-free with deeply inverted or biphasic T waves. If these T waves are seen in V2 and V3, think Wellens Syndrome.
These findings are highly specific for a critical stenosis of the left anterior descending artery.
These patients are at risk for an extensive anterior wall MI within the next few days to weeks, and if inappropriately stress tested, these patients can suffer an MI or cardiac arrest.
Continuing with heartache, our 80-year-old Asian female with chest pain ended up having Takotsubo cardiomyopathy, also known as broken heart syndrome.
The majority of cases are in elderly women triggered by a significant emotional or physical stressor, such as the unexpected death of a loved one or an acute medical illness.
Diagnosis is made when the patient undergoes cardiac angiography for presumed MI and is noted to have no significant coronary artery stenosis and left ventricular apical ballooning.
Typically, patients have full recovery within 2 months, but rarely reported complications include arrhythmias due to QT interval prolongation, left ventricle outflow tract obstruction, and rupture of the ventricular wall.
Confused as to why your patient speaking to you does not have a pulse? Check to see if they have a left ventricular assist device, or LVAD. The goal of this device is to augment cardiac output.
The components are pictured here, and variables of the LVAD, speed, flow, and power, are important to understand.
The main complications are bleeding, infection, pump thrombus, and arrhythmia. Every LVAD patient should have their coordinator's information on their person. Contact this person as soon as the patient comes in the ER.
Patients with local trauma, IV drug abuse, and indwelling catheter or the immune compromised are at risk for sternoclavicular septic arthritis.
It is typically insidious in onset. This infection can spread via local invasion and lymphatics to adjacent structures, resulting in serious and potentially life-threatening complications.
Depending on the patient characteristics, tailored antibiotics to cover MRSA, gram-negatives, and Pseudomonas.
What's cooler than being cool? Include myxedema coma in your differential of the patient with refractory shock or altered mental status.
There are a number of potential precipitants for myxedema coma, including heart disease, stroke, environmental exposures, medications, trauma, infection, and electrolyte abnormalities. So make sure to treat the underlying cause as well.
These patients are often hypothermic and can have characteristic EKG findings of Osborne waves or camel hump sign, as shown here.
Here's a less commonly discussed pathology with our 60-year-old male presenting with stroke symptoms and generalized plethora.
His workup showed Polycythemia Vera, which can present with a number of different symptoms related to impaired oxygen delivery, high cellular turnover, and both bleeding and thrombotic complications.
Then there was the unfortunate case of a 30-year-old female presenting with abdominal pain after a colonoscopy.
Patients most commonly complain of bloating and abdominal pain or discomfort.
The most common complications post-colonoscopy are perforation and hemorrhage. These patients can present directly from the endoscopy suite, but more often there is a delay of hours to days in the case of perforation and weeks in the case of hemorrhage.
A number of other complications were also discussed, including explosions.
In a child with non-thrombocytopenic palpopurpura in gravity or pressure-dependent areas, abdominal pain and migratory arthritis, think HSP.
Almost always HSP is preceded by a URI, and 95% have complete recovery after 3 to 4 weeks. Look for potential renal insufficiency, which occurs in about 1% of patients.
Speaking of kids, do you have a firstborn white male of Northern European ancestry with projectile vomiting and an olive-sized mass? Think pyloric stenosis, a hypertrophy and hyperplasia of both the circular and longitudinal smooth muscles of the pylorus.
Approximately 95% of cases are diagnosed in those aged 3 to 12 weeks. Look for signs of dehydration in these infants, including depressed fontanelles, dry mucous membranes, decreased tearing, poor skin turgor, and lethargy.
Remember that ultrasound can help in the workup of the undifferentiated shock patient. Think about causes of shock as pathology affecting the pump, the tank, or the pipes.
The rush exam, which utilizes the acronym HIMAP, or Heart, IVC, Morrison's, to remind you of the FAST exam, aorta, and pneumothorax, can help narrow down the differential.
As in our case of the 35-year-old female with ESRD, AIDS, lupus, and a ground level fall presenting in shock, the rush exam was used to diagnose pericardial tamponade and to definitively treat the patient via pericardiocentesis.
Mycobacterium tuberculosis is a highly aerobic bacteria that has an affinity to areas of high oxygen content, like the apex of the lungs. It can manifest as a primary lung infection, remain latent or dormant, or have extrapulmonary manifestations.
In high prevalence areas, positive findings on the FASH exam are highly suggestive of extrapulmonary TB. The FASH exam looks for ascites, pericardial and pleural effusions, periaortic lymph nodes, and local liver and spleen lesions.
If you see jaundice, conjunctival suffusion, and viral syndrome in a patient who just completed a triathlon in Hawaii, consider leptospirosis on your differential.
Humans contract the bacteria from exposure to animal urine, contaminated water or soil, or from contact with infected animal tissue. Risk factors include handling of meats, hiking, trekking, and triathlons.
Progression of the disease can lead to meningitis, transaminitis, proteinuria, hematuria, and uveitis. Treat these infections with IV penicillin if inpatient, and doxycycline if the patient meets outpatient criteria.
Just as with leptospirosis, make sure to ask about travel in all patients when appropriate, as some diseases are not endemic to your area and could be missed if you do not know where the patient has been.
Not all patients with myalgias and fevers are just viral syndromes. Careful history taking will change management, as some of the mosquito-borne diseases have vaccinations or prophylaxis, so don't forget to recommend these to your traveling patients and to also mention ways to avoid mosquito bites.
So that's it for part 1. Be on the lookout for part 2 of our year in review.
Send us your comments, suggestions, and cases to theclinicalcorrelation@gmail.com and follow me on Twitter @MDNotified.
And me at EMLU.
Thanks for listening.